Thank you for that kind welcome. I'm very excited to share my perspective from the lens of just one social justice institution, Lynn Community Health Center. Just hopefully everyone can see my slides. Maybe you can just put in the chat if that's showing through okay. It's hard to tell on the side. Thank you. Oops, there we go. Oops. There we go. All right. So in order to start talking about health equity, I think we first must recognize this linkage between what we know as structural racism and health equity, meaning that race is really a social construct that has been used to categorize human beings, but race alone, truly, does that mean that based on your race, you have a higher risk of certain disease than maybe another race, right? So for example, a recent study of cardiovascular disease found a higher risk of descendants of African-American slaves than more recent African immigrants. So why is that, right? Why is that when I think we really must take a close look at social determinants of health and really the long-term impacts of discrimination, racism, and segregation in our country. And in fact, I think it's really less about race and more around the systems of advantages and disadvantages in our country and the impact of those over time. So given that this problem is so deeply rooted, right, it's hard to even know where to start. So for us at Lynn Community Health Center, it really took a deep look at first ourselves as an organization and where we've been. And then also as an organization, we've been on what we've called the lean journey, which is an improvement methodology that helps us improve systems and processes. So for us, why not leverage what we've learned there to also tackle some real world problems around health equity? It's not perfect, but I think the most important thing is that we got started. So for me, in my career, I started in an academic medical center. So when I joined the community health center movement 6 years ago, I don't think I fully understood the impact of community health centers and our health system in this country, right? What surprised me was not only the reach of community health centers with almost 15,000 locations around the nation and lots of comprehensive sets of services like Lynn Community Health Center. We offer behavioral health, primary care, dental, so many different services. But what I found surprising was that community health centers could provide care 24% cheaper than all other healthcare systems. And so in fact, in the United States, community health centers were saving the US health system $24 billion annually. So as a systems engineer, I felt lucky. I felt like I stumbled upon this really unique opportunity. And how great was this to merge this passion I had for system improvement with making a difference, not only at my CHC, but potentially one day beyond that, more nationwide. And also thinking about how can we use the CHC movement to have a system impact, especially when community health centers take care of over 28 million patients, 91% are low income, 5% are homeless, and 58% are people of color. So by far, the social determinants of health factors in community health center far outweigh patients in the rest of the health system. And CHCs can do this all by providing high quality care and at 24% less the price. So for me, this was a really great opportunity. So a little bit more about Lynn Community Health Center. Lynn Community Health Center is a social justice organization really focused on the most vulnerable, so regardless of one's ability to pay. We're located north of Boston and have 650 employees caring for 43,000 patients. So that's about 50% of the population in Lynn. And like other CHCs, 90% of our patients live at or below the 200% poverty level. And so essentially we don't turn anyone away and we serve everyone who comes to us. When you walk in our lobby, this is what you see. There's a big quote on the wall, and I think it just really highlights our mission and what we stand for, right? And we believe healthcare is really this right and not a privilege of the few. So let's start to talk a little bit more about health equity and what that looks like, especially in the US. I think just some facts from IHI. When we look at life expectancy, even with improvements over time, life expectancy for Black Americans has lagged behind those of white Americans since 1950. In fact, life expectancy for Black Americans in 2010 was equivalent to those of white Americans in 1980. And when we take a look at the specific disease states, let's take cancer rates, for example. According to the CDC in 2004, cancer rates were 1.2 times higher among African Americans than among white Americans. I think it also should be noticed that health disparities are not limited to race and ethnicity, right? So according to IHI, households with lower incomes have a higher relative risk of mortality. And I think this was really highlighted also in a recent study from the Massachusetts Health Equity Task Force. When they took a look, there was a study done by the Federal Reserve Report where the net worth of a white Bostonian is $247,500, while the net worth of a Black Bostonian is only $8. And so this inequity, inequities like this really have led to the inequities in healthcare. And I think, again, like the study that was done in 2020, the state of Massachusetts formed this health equity task force to really study this and make recommendations, not only for addressing health disparities for underserved populations, but particularly in the times of COVID, and how has that potentially worsened over time. So the task force ended up making many recommendations to address many of these social and economic factors, such as housing and income and food access that has really gotten worse throughout the pandemic, and really recognize that the access to quality healthcare accounted for only 20% of somebody's health status, right? And it's really these social, economic, and environmental factors, including where people live and work, where they spend their time, as well as the effects of racism that count for the other 80%. So you might be asking, has this probably gotten worse or better throughout COVID? I think the answer is worse, right? But I think the silver lining is also that now we can start to see it, that this has really come to the surface in many ways. We know that COVID has disproportionately impacted our communities of color, with higher infection rates and death rates in particular. And I think what was striking to me, and Lynn, I remember at one point in the pandemic, our COVID positivity rate was 23%, where the state overall was seeing an infection rate of 7%. And when you looked at other communities like ours across the state of Massachusetts and in our Black and Brown communities, you saw very similar statistics. So I think like COVID has really helped to expose the social and economic inequities that have always been there, right? And been drivers of health equity, such as food insecurity. And I think this blueprint for health equity and the task force that was formed at the state level really helped to identify some of these opportunities. So a few members of the task force, this was actually published in July 2021, and a few members of the task force were interviewed. I'm going to share a snippet of the interview. I think it really summarizes really nicely where we are as a state when we think about health equity. So Dr. Kiami Mahanya, our CEO, was interviewed along with Michael Curry, the president and CEO of the Massachusetts League of Community Health Centers. So I'll just play a short snippet of that.
And there's no audio.
Oh, there's not. Okay. Let's see. Might need to Oh, I forgot a setting. Hold on one second.
There have been racial disparities in healthcare for as long as there's been healthcare. But this past year, higher rates of COVID cases and deaths among communities of color shone a light on some long-standing inequities.
I want to declare racism to be a public health crisis in the city of Boston.
That was former Mayor Marty Walsh last year, and recently the state's top doctors group made the same declaration, with its president saying in a statement the Massachusetts Medical Society views healthcare as an inalienable human right, and for far too long injustice and racism in myriad forms has interfered with that right. And now a task force convened by the state legislature is out with a new report that calls on the state to take specific actions to address healthcare racism, writing, "The disparities in COVID-19 morbidity and mortality are the direct result of long-standing inequities in access to opportunities and resources for Black, Latinx, and diverse communities of color," adding, "Returning to the pre-pandemic normal is not an option. Normal created the conditions that led to these disparities. We must seize this opportunity to build a more equitable and resilient future for all. The time to act is now." Joined by the co-chair of that task force, that's Michael Curry. Michael, of course, is the president and CEO of the Massachusetts League of Community Health Centers. Another task force member joins us, Dr. Kiame Mahania. He's the CEO of the Lynn Community Health Center. Doctor, good to meet you. Michael, and good to see you as always.
Good to be back.
Michael, thank you so much, Doctor. Michael, what was the mission? What was the task force charged with a year ago?
Yeah, it was a pretty broad scope for the task force. 16 members. We were charged with meetings regularly. We met 17 times over the last year, 3 public hearings. And we were charged with looking at the disparities in COVID-19 and as they played out for people of color, for Black, Latinx, folks, for people with disabilities across the board. We were seeing those disparities play out and working as a task force to look at the underlying issues, to address shortages of PPE, equitable access to care, the disparate hospitalization and death rates. We were looking at the data there, and then proposing recommendations to deal with the underlying health equity challenges that existed way before COVID-19 that we, quite frankly, should have addressed a long time ago.
Michael, when you mentioned the underlying challenges, what I thought when I was reading the report is it's sort of analogous, at least in my estimation, to how Joe Biden views infrastructure, for example. It's not what it used to be. It's not narrowly roads, bridges, physical infrastructure, but a broad spectrum of physical and human infrastructure. That's sort of analogous to how your task force viewed the challenges around health equity. Is that fair?
I think this is a great comparison. We knew doing this work, and I've been doing policy work in healthcare for most of my adult life. Yeah. We know that it's not wise to have people getting their care in the emergency room. We know that hospital emergency rooms and hospital settings, inpatient days are costly. We know that we can do things to prevent sickness and ensure people live longer lives. And what we should have known, and Dr. Mahania knows this, is that the underlying issues for much of this sickness was social determinants of health. It was racism, it was poverty, it was food insecurity, housing insecurity. So they're inextricably linked. And I was glad that this task force made that connection and did not stick to directly COVID issues, but really talked about the underlying issues.
You know, Doctor, is it a growing body of conventional wisdom in your field that these social determinants, as Michael described them, are as essential to addressing health equity issues as the healthcare delivery itself, or is this still seen as a sort of a marginal kind of approach?
No, I think there's been a consensus in the healthcare field for several decades now that what actually happens in a hospital or an outpatient doctor's office or with the nurses or nurse practitioners or PAs, that's actually a fairly small part of what contributes to a person's health and well-being. I don't think that's new. I think what's new is the embrace beyond healthcare of the fact that this is true, that you can't talk about healthcare without talking about some fundamental background.
You know, you also can't talk about healthcare, Doctor, it seems to me, without dealing with some of the biases that are sort of baked in to some of the people providing. I will never forget, I've discussed this with Michael, the study that came out, was it 5 years ago, I think, of white interns and residents and some medical students who were surveyed. Overwhelming numbers of them believed that Black patients had thicker skin. Black patients were more resistant to pain than white patients. How do you address these things, it seems to me, without which you never get to the end zone?
Well, I think that certainly interpersonal or personal bias has a strong role to play in the sort of the racial impact of inequities. But I think more, and I think you could hear it when Michael was talking about the changes that are needed, it's more a question is, are we going to consciously take into account the fact that these disparities exist as we are designing the systems of the future. And so I think that one of the first steps that we're recommending through this report is really that when we're designing a law or designing intervention, that we think long and hard, will this have an equitable impact? Meaning that will we be able to address this particular, whether it's a transportation bill or a zoning bill, are we making sure that we've looked at what impact it would have on people of color? Because of course, what tends to happen if you're the decision maker is that you make decisions based on people that you know and problems that you know. So we really, what we're encouraging is people to look beyond that.
You know, Michael, when I hear.
All right, so what Kiami is really highlighting here is this need to take a look at the structural racism that exists, right? The systems in place that have a negative impact on health equity. And to quote, I read this article the other day. I just want to share this quote because I think it's really relatable to what we're talking about today, from Denny Butler McKay, a clinical social worker from Southern Jamaica Plain Health Center. Recently, it was highlighted by the Boston Foundation. What she said was, it's been called a system of advantages based on race. It's not interpersonal. It's not even institutional. It's the connection between systems over time that have formed the basis of racism, right? And so I find this lens, if you haven't seen this before, this lens of systemic oppression to be really helpful and a helpful framework when thinking about this, and especially when you start to have conversations about health equity and racism and the intersections. To be able to identify what are you talking about? Are we talking about individual oppression, right? Where we're talking about maybe explicit or implicit bias, and so that's more individual based, or are we talking about the interactions between individuals? So more those like interpersonal, such as microaggressions that we can see, or are we talking about really that systemic lens and putting on that lens, which I think is what Kiami and the Massachusetts Health Equity Task Force was really tasked to do, and think about what are the underlying causes. And are we talking about institutional policies? Are we talking about maybe how the institutions interact with one another, right? How are the structures across our education, health, transportation, economy, right, interacting, and those relationships between institutions and how they may perpetuate or reinforce over time unequal opportunities. So I find this really helpful as we start to have this conversation. So as an organization, where do you begin? And this is a huge challenge, right, that we're facing, and we're all facing day to day. So both individually and then as organizations, where do we start? And this is where I pose this question, right? Is hope truly a strategy? And I think this question may be a little bit pejorative, but really, how do we start to turn the vision that we all have into action? And how will we truly make a difference every single day? And when we started, in fact, there's dozens, if not hundreds of different examples and frameworks and resources out there. So it can be pretty overwhelming, I'll say, and it's hard to figure out, like, where do you start and where can you quickly start to make some headway when it's so easy to get lost in all of this and get paralyzed. So with so much out there, like, where do you start? So for us in 2020, it started, and really before that, but more intentionally, I think in 2020, was this effort to take a critical look at ourselves, right? Are there any patterns of inequity in our organization, especially one who prides itself on being a social justice organization and having a mission like ours, right? So we focused on this problem to solve, right? Start to explore possible sex, racism, ethnic disparities within LCHC workforce, and really start to understand this problem and if we had any inequities in our workforce. So we started this by analyzing first our staff demographic data based on position, and this ranged from frontline to leadership. Determining if there were any patterns, and then comparing our employee demographic data to those in our community, right? We're here to serve the community of Lynn, so how well did we represent that community? Demographic data was provided by HR, and then we also created an anonymous survey to gather staff opinions on racial, ethnic, and sex inequalities within the workplace. And so to do this, 2 students worked on this project through the Primary Care Leadership Program. This is a great program if you haven't heard about it. It's founded by the GE Foundation and National Medical Fellowship. And their goal is really to increase access in primary care for the underserved. And so what they found was that, in fact, 85% of LCHC employees identified as female compared to nearly more of a 50-50 split in our community. So this wasn't uncommon, right? In healthcare, we tend to see more females than males in healthcare roles. But when they started to dig deeper, I don't think sex was necessarily a driver, but when they started to dig deeper on race and ethnicity, I think that's when we actually started to see some disparities, right? And particularly when we surveyed staff, 90% of employees did not take or did not recall taking any type of diversity and inclusion training. Although 99% said this would be really helpful. So this was a really tangible place that we knew we could get started. Also, there was a proportion of our staff that were concerned with our ability as an organization to discuss race in the workplace. And all of those who said that, right, came or identified as a racial or ethnic minority in our organization. So I think more interesting, we took a closer look at our employees and managers based on race and ethnicity and compared that to the city of Lynn. So the bottom bar there is the city of Lynn's population and breakdown versus the middle bar is all LCHC staff, and then the top bar is our management. And so I think some reflections here, staff positions, I think pretty closely reflected the Lynn community itself, right? When we look at that middle bar and compare that. However, we noticed that employees who identify Black really remain unrepresentative. And so that was maybe an area we wanted to focus on. Now, when we moved into leadership positions, this is where we really started to see the disparities, right? Especially comparing the larger population of white when comparing to the city of Lynn. And so as we moved up the hierarchy in LCHC, we noticed the population became increasingly white and male and really less representative of the Lynn community. So for us, we started breaking down this problem, too many white managers, basically, and why was this? And we got to thinking really about the proportion of managers we were hiring internally versus externally. As one of the largest employers in the city of Lynn, we also pride ourselves on being an opportunity for employment in the city of Lynn. And then we also pride ourselves on giving opportunities to employees to grow. So many of our employees are in school to become MAs or nurses. But I think where we had a gap was, were we really thinking about employees who wanted to go into leadership, and how are we starting to foster that skill set? So for me, this area was actually a particular passion of mine. Lean thinking, which I'll talk about in a little bit, is actually anchored in developing people through improving the work. And so you really have to do both. It's not good enough to just improve processes if you're not going to improve the people along the way. And so years ago, we started offering opportunities to frontline employees to develop more hard skills. So for example, on each of our primary care teams, we created what we call an operations coordinator position. And their role was really to assist the manager of the department in managing patient schedules. So this could include like blocking schedules if the provider was on vacation, or if somebody called out last minute, canceling those patients, rescheduling, or even building next month's like patient template. And so this was an add-on to somebody's current position. So they could be a care coordinator, an MA, but somebody in or receptionist, somebody in a frontline position that had an interest for growing their skill sets and starting to think about what are maybe some of those hard skills that you may need if you wanted to move into, let's say, a supervisor or manager position. And so in the grand scheme of things, these positions weren't really like needed, right? It wasn't like we were desperate to have this on every unit, but it really gave our frontline employees an opportunity to build those skills and just start to develop new relationships as maybe they explored opportunities of leadership. So early on, we were starting to build these career paths. And so we wanted to build on that idea, right? How do we become more intentional, and how do we start hiring from within to really even out this picture? So with that like deep look at ourselves, it generated a number of next steps for us, intangible things that we can do, right? Starting with like racial equity training that was more intentional and obvious. And at all levels, right? We started also with a compensation survey. So we were happy to find there was no disparities based on race or ethnicity, but that was something we did. And then the other thing we did was we formed a committee on racial equity. And so we called this our core committee. And that core committee was tasked at looking at our institution and continuing this work and really holding that racial equality lens, and to start to actually make recommendations on our next steps. And actually they had a direct line to our board of directors so that these ideas were not passing even through leadership, right? That they had the voice of the board and that authority to really make recommendations based on what they were seeing. And so I think this really was our launching point. And then that core committee started monthly discussions at an organization level. So there are lunch sessions that happen once a month where either it's a book or a podcast or an article or maybe a movie that was assigned where you could watch that, listen to that content ahead of time and come and have a discussion with your peers. And so it was open to anyone in the organization. And so again, this was an opportunity to start to get people talking and engaging in these conversations. StoryCorps was actually an idea inspired by NPR's StoryCorps program. And the idea is, again, to develop this muscle and how to share our own experiences around race. And as an individual, like taking that time and thinking and doing that inner reflection and sharpening your thinking and helping us develop actually a library of stories. And then I touched a little bit on that career ladder piece, but again, like that internal versus external hire, how do we start to build a workforce that has the skills needed so that they can actually move into a supervisory position or a management position? And so all of this was really our initial steps as we started to learn more. And like many organizations, we developed a racial equity plan for how we as an organization would start to address both internal equities and health equities of our patients, right? So it wasn't easy, I'll say, to take that honest look and really be transparent and honest with where we were and where our gaps were. But it was the first step as we aimed as an institution to take some control. And we realized our organization path forward was based on like our situation though. And like every organization is going to be unique. And so everyone's framework will look slightly different. So in order to talk about our next steps, I really have to rewind about 6 years, right? It started to become clear that we could approach this problem of racism and health equity as a real problem to solve, similar to how we might approach a process problem. So to better explain this, I really need to rewind to the beginning of what we call our Lean journey, as this is really the anchor as we were thinking about our next steps forward. So first, what is Lean? If you haven't heard of it, it comes from actually the Toyota production system. And I think this Lean transformation framework from the Lean Enterprise Institute really does a great job at explaining what this is. And it really starts with your value-driven purpose. As an organization, every organization has a unique and their own local context. So it's important to identify what problem as an organization you're trying to solve. And at the base and the foundation is really that the principles and basic thinking. And so some of the basic principles are the fact that we really want to put our customers or our patients first, right? And center of care around our patients. And then second is acknowledge that employees actually are our most valuable resources, right? It's not our space or the stuff around us. It's really the employees that drive the culture and drive the care that we provide for the organization. Direct observation is also really important, like knowing that you are going to see firsthand to identify what are the real problems. You're not sitting in a conference room, dreaming up the problems or interpreting what you think the problems are. And that, in fact, you're trying to get improvement out there so that everyone and every day can participate. and that all these little ideas, if we can get people rowing in the same direction and actually problem solving together, we can really start to achieve our goals. And then the pillars, process improvement and capability development, is all about how do you study a problem and understand a process and make incremental improvements. But at the same time, it's very important that you're bringing people along and you're developing improvement capabilities of employees at each and every level. And so this is really grounded. I think all of this, if you think about the house and what's in the middle, is on a strong management system, right? And that the leadership behaviors also need to change to start to foster this environment of improvement so that you don't have a top-down program. It's really a bottom-up and about the employee engagement every single day. And if you think about a typical process that you see, maybe a patient arriving to when they get treatment, the other thing I'll point out is that any typical process has about 90% waste, and this has been studied for years, and only about 10% of a process is value added, right? Or that it really changes or adds value to a patient's care. And so traditional employee improvement really focuses there, right? How do you make your employees work harder? Do you need to add people? Do you need to add space? How do you work longer? And so it really focuses on the value added parts and making more of that. And a lean approach in its most simple, basic terms is how do you focus on the waste and actually removing the waste and reducing the waste so that there's more time to do those value added activities for our patients. So it's really about providing value for customers with less. So like I said, in 2015, we started our journey on this path as we started to embrace these principles and how we were leading Lynn Community Health Center. And we invited our friends from the Lean Enterprise Institute, and we started by taking a walk in our community. This was surprising to them. They hadn't really been to they've been to lots of organizations, but it was the first time that an organization started by actually walking the community. And so they knew that there was something special about us, right? That we really saw our business as the whole community and the care that we provide in the community and not just what happens in our four walls. And we started to talk about our problems with them, right? Years of adding staff to keep up with like our increasing demand that we were seeing. We had recently doubled our space. We still couldn't meet our demand even though we had doubled our space. And our CEO at the time, Lori Berry, really deemed this as like a productivity problem. And how can we get our doctors to see more patients, right? And so our friends from LEI listened and asked some good questions, but really the main question they asked was, okay, so your demand is really high and you're seeing less, why? And what's currently happening, and do you know, and have you gone to see? So they got us, and our coaches from LEI got us to focus on the work, right? How can we start to make work easier for our employees, better for our patients, faster, more efficient, like squeezing out that waste, and ultimately recognizing that costs will come out, productivity will come, but that's the last thing to focus on, right? That easier, better, faster, cheaper, that's our focus when we're thinking about how to improve something, but we're doing it in that order, and we first have to make the job easier for our employees. And so building capability around solving problems was very important to us, right? And so we did this on first starting on one of our primary care teams. And so remember, our leaders thought this was a productivity problem. So it took us a long time, but we finally got to like a problem to solve and a clearly defined problem to solve and a focal point, which is why do patients wait? And this really helped us frame our problem from a patient's perspective. And so for me, this really hit home. In my first week at Lynn Community Health Center, I did a few patient tracers to gain an understanding of our system. And one of my observations was a middle-aged Latino man. He had arrived early for his appointment because he had a bill that he didn't understand. And after talking with the front desk staff called over the manager. Ultimately, the physician got involved with the bill. At the end of it, like he still didn't understand why he received this $600 bill. And I waited with him all throughout the process, and we waited together and we talked. First it was 50 minutes, 50 in the waiting room, 30 minutes in the exam room. That was really excruciating. And then another 20 minutes in the lab. his provider was really, really worried about a health condition. He wasn't adherent to a medication he was taking. Honestly, I couldn't even tell you what condition that was at this time, because really all the patient cared about was, I have this bill and I can't pay it. And what am I going to do? And that's why he was there, right? It turned out a bill was from a contracted lab service, and no one was able to explain this to him or get him help, right? And so he left really worried about this. And the last thing he said, right when he walks out the door, he had actually taken the afternoon off, and his visit was about a total of 3 hours. So it was not a short visit by any means after he had gone through all these process steps. And the last thing he said to me is, now I have to go back to work. And I looked at my watch and it was like right 5 minutes before 5. And it was just like very clear to me that, time is really precious for our patients, that when we think about our patients, they may not have a bank of, vacation time or sick time like we do to take off, like that a 3-hour visit really is not acceptable when he has a question about a bill or even his health condition. And how do we start to think about time as being really precious and decreasing and squeezing out all those wastes? And so for us, time really became this focal point that hit home to both our mission and the business problem, right? That's the productivity problem that our CEO really wanted to solve. So we started to get to work on this problem when we formed a multidisciplinary group. And I want to introduce you to Denise. She's a medical assistant, and I'm going to play a video of her explaining some of her improvement work that she was doing with the team. And take a listen, not really for the solution that she's talking about, but really about like, what is her process that she's using to problem solve.
Hi, my name is Denise Cabrera. I'm a medical assistant, also known as a clinical assistant on the Blue Team at Lynn Community Health Center. One of our first experiments was the in-room checkout. So our problem was patients were waiting in long lines at the front desk for checkout, and or they would leave without scheduling their follow-up appointments. So most of the providers are waiting for the CAs and they couldn't tell where we were. Providers needed to search for us to give the patient their instructions, and only 13% of the patients were actually checking out and leaving with their appointments. So before, our current state was 50% of patients would wait from 5 to 13 minutes for checkout, causing really long lines over at the front desk. And so we tried this experiment where we would put timers on 3 of the providers' doors, and we would time them for 5 minutes. As soon as they would click print the after visit summary for the patient, they would click the timer would start ticking down under 5 minutes. And if we were able to go into the room, give them their patient instructions, give them their follow-up appointment, we would click green. We would put like a little green line. If they waited for more than 5 minutes, it would be a red. And so that's why we have the green and red smiley faces on the board. We would collect that data with the week. And so the first week that we did was 46 to 8. So 85% of those patients were checked out, and 36 to 2. Then we finally got to 71 patients were checked out and 0. Again, 23 and 0. And then we took vacation, and it kind of got back to, we didn't check out 10 patients. They waited more than 5 minutes inside of the room. So we wanted to know why they were waiting more than 5 minutes once the timer went off. So what we did was we started tallying it on this different board with the green and the red smiley faces again. And so we would write the initials of the clinical assistant and the provider they were working with and the date and what session, since they have AM and PM sessions. And if the timer did not go off, then we would put a green one. And then if the timer did go off, it would be over 5 minutes, we would put a red one. But this time we were putting the reasons why. So there are a couple of reasons why. So needed a flu shot, or they needed a point of care testing, or they needed any paperwork, or they couldn't find us. So these are just a couple of reasons on the red slots as to why they were waiting more than 5 minutes and why the timer went off. So now that we knew that it was working, we started spreading it across the team, and most providers started trying it with their clinical assistants. And so what we were doing is daily we were tracking how many patients were being checked out, and every patient that was being checked out under 5 minutes would have a tally mark. and every patient that took over 5 minutes wasn't tallied. So what we were doing was a friendly competition within the team with all the clinical assistants, and we would see who would be able to check out most of the patients in the room during the week. And so some of these are blank. There are 8 providers on the team, so not all of them are on the team at the same time. So you do see some blank, but for the most part, you do see some of them have tally marks and how many we were able to check out. So eventually the checkout became part of our job description. And in one of our many lean experiments, we even added the checkout button over here, and we wanted to see how the clinicals were doing on their own. So they would come, we would personally come to them, have a talk with them. How do you feel about this process? How do you feel about the checkout process? And they would either let us know if they're learning still or if they feel like they're a pro. I'm a pro meaning they have no questions about it. They are all set. They know what to do and they are doing it for every patient. Learning means that they're still learning. They still have questions. It's not happening all the time. So now our patients aren't waiting in long lines, taking up a lot of space at the front desk. We know that they are all leaving with their follow-up appointments as needed. And right behind me, this space is what would have been a checkout space, but now we can use it for OAs, clinicals, and providers to all sit together.
So Denise had no formal training right before this, right? But look at her confidence, right? We were teaching Denise and her colleagues how to solve problems in the moment and how to solve problems closer to real time, right? She wasn't waiting for some monthly report to come down to tell her where the problems were, where, you know, usually it's impossible to see on some of those reports, like what's actually happening. She really was rolling up her sleeves with her colleagues, collecting data day in and day out and problem solving along the way and really celebrating as they were seeing those wins together, right? She truly felt like she was empowered to solve a real business problem. And so we were doing this, like solving problems and coaching staff at the same time. And remember, I talked a little bit about career ladders. Because of this work, right, Denise started to become the star, right? She was really recognized on her team. So when an opportunity came for a lead MA position, she was clearly the choice, right? And her name went to the top of the list because of these skills that she was starting to get and the improvement work that she was starting to do. And so that was really exciting to see. So part of this process, like how did even Denise get to that point in her transformation, right? One big thing is really about building habits, right? How do you build a habit of improvement? And so we call this like PDCA improvement, plan, do, check, act improvement. And so it's the cycle of improvement where you're focused on creating a plan, running a quick experiment, reflecting, capturing that learning, and then iterating, right? She didn't get discouraged when they were at 100% and then they fell back down to 85%. She just asked herself, okay, what's the next step and what's my next move to figure out where to go next, right? And so we use these forms. It's a really simple PDCA form to get people to document, like first, what's the problem you're trying to solve right now? What's the impact of that problem? And then make a hypothesis, right? What's your proposed countermeasure that you're trying to do? And then if based on that, right, going back to like basic science, right, you made a hypothesis, what do you expect the result to be? And how will you measure that and how will you know, right? Then go conduct an experiment and come back. In our case, we were doing this on a weekly basis. Come back and say what actually happened and what did I learn from that, right? And what will I adjust for this week to keep learning and to solve this problem together, right? So week after week, we were building this habit, building this confidence in our staff, and we were starting to develop our workforce in a new way. And then fast forward, right, the pandemic started to hit. And so we wanted to use this type of daily problem solving to help our organization get through the pandemic. And we knew that this was a strength of ours. Just a little bit of context and I know we're all in the Northeast, but if you look at in May 2020 in the United States, arguably had the worst outbreak in the world, right, with the most number of cases per capita, right? And in Massachusetts, we were experiencing the third worst state in the country, right? And in the city of Lynn, we were the third worst in Massachusetts. So comparatively, you could say that Massachusetts and Lynn in particular were one of the hardest hit areas. So we had this daunting task ahead of us as we thought about how to react to the pandemic. So Kiami, you saw him on the video earlier, our CEO, really set this direction up front and aligned us around our problem to solve. Remember, I talked about the need to have a clear focal point so that we're all rowing in the same direction. So his true north and what he set out as the vision was actually to protect the hospital. And so anytime that we had a question on what do we do or where do we put resources, we always came back to this focal point of how do we protect the hospital. And for us, that was really important because we are the major healthcare provider in the city of Lynn. So with limited resources, our nearest hospital, which is in Salem, about 15, 20 minutes away, we didn't want that emergency room or that hospital to become overrun with our patients, right? So for us, it was all about how do we stay open for our community and preserve the limited capacity that we had at our local hospital. And so this got us really focused on what we wanted to do. And so through the pandemic, we used this lean thinking to create dozens and dozens of standards throughout this emergency. And we focused on learning fast, right? This was a big learning for our middle managers that we didn't have time to wait for perfect, that we had to learn as quickly as possible so that we could see problems more clearly. And sometimes this meant putting in a first standard just so that you can see, right? It could be a bad standard, but just something where you could start to see where you were and measure it and improve it. And so sometimes these standards were even changing multiple times a day because we were so focused on learning. Kara Keating Bench is a family physician who is helping lead our COVID response effort. I'll let her share just a minute or so about her reflections and insight on this process.
Problem solving, lean problem solving in particular, really lends itself nicely to a physician's mindset. So even though physicians themselves might not necessarily be trained in lean principles in practice, the actual process is very much like the physician's diagnostic process. Right. So if you think about that, I think it's Einstein says, if I have, an hour to solve a problem, I'm going to spend 55 minutes of it defining the problem, and then the solution falls right there. So I think that's kind of the same thing as really listening. And so like when you're a physician, you have to listen to your patients to find out what are the pain points, right? What's causing the problem, and asking the clarifying questions, right? So okay, you're having this problem. Well, what are the pertinent positives and negatives, right? Those are the terms we use as physicians. And then, okay, so how do I actually figure out what this problem really is? So I have a sense because I've talked to you, as a physician, and then so really listening, and then figuring out how do we actually like show that problem? Like how do we make that problem visual?
And so we were building these first level standards and developing, right, managers like Kara and others that were really starting to embrace experimentation and learning fast and inserting these standards so that they could start to see their problems more effectively, right? And so by doing this, we really created energy around building and developing our middle managers to own huge pieces of our response, right? From testing to PPE or how we delivered telemedicine care, right? But all of these flows are really important. That as leadership, we couldn't do this in a top-down way. And I think as we think about health equity, it's the same thing that we're starting to think about. Like we have to start to engage our workforce, our managers in this process. Like it can't be this top-down exercise. And so one key principle too is like we were learning right by doing. And so I liken this to like a flashlight analogy, right? So oftentimes, like especially within COVID, like you don't know where you're going to go or what you're going to discover, but it's important to shine that flashlight in the dark. And then as you take a step forward and as you learn and you take another step forward, you can see a bit further, right? And so it was all about how do we start to take these incremental steps forward to tackle these really hard problems. And I think we demonstrated that throughout the years and through COVID. And so as we started to turn our attention to health equity problems, especially as we thought about health equity when it came to the pandemic, where do we start, right? And so lean thinking really helped us solve problems in a very tangible way. And so started with thinking about health equity problem. Our first one that I think we more intentionally really took on was equitable distributions of vaccines and thinking about what that was going to look like for our patients. So early on, like when we reflected through the pandemic in March and April of 2020, things like testing supplies were really limited, right? And we could only test our symptomatic patients, and test kits, a lot of them, most of them were going to those major hospital systems, and communities like ours really had to fight to get those resources. And I would say PPE was the same thing, right? Large health systems had those big contracts. So who do you think got the supplies, right? It's those big contracts. And so all along we were recognizing that there's these disparities. And so we really didn't want to be behind the 8 ball when we started to think about equitable distribution of vaccines. I'll highlight this map because I think this tells it all, right? In January 2021, it was clear to us that, right, Black and Brown communities were being infected at a much higher rate of than maybe white neighborhoods, right? And they had higher death rates. The likelihood that they'd lose their job or fall into poverty was higher. So despite all these warning signs, right, it was clear that this vaccine effort was just going to be one more potential disparity, right? And so in Massachusetts, you know, a lot of articles were written on this leading into and then throughout this vaccine distribution. And in Massachusetts, right, the major vaccine supply was going to these mass vaccination sites. So you see on this map here, this was the nearest mass vaccination site to our patients, right? You can see the orange line is Lynn, and the nearest vaccination site was 28 minutes by car, right? Public transportation was really, really difficult or non-existent. So how could this be the nearest option, right, for our patients? And this is a city of 100,000 people, right? And so this made us really take, again, a close look at this. So as we thought about our plan, we only had about a week to figure out, like, what are we going to do? Are we going to rely on the mass vaccination sites that was 28 minutes away? Are we going to try to do this ourselves? We got together with Mass General Brigham, Salem Hospital, and the city of Lynn and the city of Nahant, and decided as a team we would open up a mass vaccination site ourselves, right? And so that's what you see here. And on February 1st, which was really when the phases opened, we launched our mass vaccination site. So we took one of our schools, and LCHC took the operational lead. We were proud to say we were able to offer all 3 vaccine types, and we built the capacity to see over 7,000 patients per week. So really a huge amount to be able to care for our patients. Just astonishing numbers to me was the amount of people that this took to pull off, right? We had 742 staff shifts that needed to be filled each and every week. So just a major operations that we were able to launch alongside our partners and with support from the community. One thing to think about was that health equity actually started up front for this. So when we you know, you thought about opening up our own mass vaccination site, we had no good option, right, in our community. And so it was important that with the limited resources that we had, that it actually went to our community. And so we made hard choices. This is the line coming in, right? And that it actually started with the screener at the front, right? They were not only screening for COVID symptoms, but they were also making sure that the patients that were coming to this site, it was open to all citizens, but citizens that lived in Lynn or Nahant. And so really making sure that we weren't, and we saw people come over from all over the state because it was so hard to get a vaccine, but we really held true to getting access to our community. So I think this was a hard decision, but again, I think this gave preferential priority to our high-risk community. And along the way, we were also monitoring some key statistics, right? Age, and our race and ethnicity and language data. And so week by week, we were taking a close look at who were we vaccinating. And at first, you know, as you can see here, it was really following the phases that the governor had set out in his initial plan, right? The 65 and older, and then February 18th, 65 and older with like 2 or more comorbidities. And then eventually April 5th rolled around and it was 55 with 1 medical condition, right? There was actually like 6 different requirements right along the way. Every week it was something new to react to. But we wanted to make sure that as it started to be less constrained and it became more of a patient option, that we had good data so that we could monitor and make sure that we're taking care of our community. Here's our race and ethnicity data that you can see. And even with us ensuring that patients were coming from the community of Lynn and Nahant, right, we saw this disproportion based on race and ethnicity. It really didn't match our city demographics, right? Which was 49% Hispanic, 31% white, 12% Black. Like, you just didn't see that. And the white population that was getting vaccinated at the time was just much higher than those that actually lived in, than the proportion that lived in Lynn, right? And same thing with language. I think we saw, and we were concerned, right, that if you took a look at our health center patients, over 83% were people of color and 53% were best served in a language other than English. And so we were having a difficult time, I think, reaching our patients, and specifically our Hispanic and Spanish-speaking patients. And so in April 2021, it became clear that this was starting to be a national problem, right, with Black and Hispanic patients in the US having dramatically lower vaccination rates compared to white counterparts. Of those vaccinated with at least one shot, only 9.5% were Hispanic, compared to the Hispanic people making up 18% of the population, right, when you make that comparison, and white people making up 69% of those getting vaccinated with at least one shot, even though they only counted for 60% of the population. So we were really starting to see this disparity play out, even with this really intentional rollout of vaccines. And so as vaccines started to, like, demand started to wane, and we were starting to get into those that were hesitant or had questions, we started doing a lot of outreach to our patients, right? And it's the typical stuff. It was the text messages or the MyChart messages. You know, we had citywide marketing with buses and signage, those town hall forums. We were starting to make outreach calls. We had like online booking options for all of our patients, or patients could walk in to either be seen if there was capacity or schedule their appointment and get help doing that. But still, I think we were seeing this disparity. And in fact, in April, we were making hundreds of outreach calls every single day, right, to our most vulnerable patients. But I will say we were focused on those high-risk patients, right, with certain disease states. And I think that even looking back, it's like, oh, those are the patients that have multiple services and probably have other people, not just us, calling them to get a vaccine, encouraging them to get a vaccine. And so it was something that we really started to learn and collect data on, and were we actually getting a return for all these calls that we were making? And still at our mass vaccination site, we were only actually vaccinating 25% of the people being vaccinated were our patients, which was really surprising, right? As we know that it represents about 50% of the patients that live in Lynn. So this is where we really started to engage what our PDCA thinking, right? So Paul, our manager of our vaccine program, started to develop tracking sheets for the staff to use so that they could learn quicker and improve the vaccination rates in the community. So the team started to track each and every outreach call, whether it was a scheduled vaccine appointment, a patient declined, maybe they were hesitant or they would like to speak to a nurse. We actually have an escalation process that they developed where a more administrative person would call, and if that didn't work or the patient had a question, then it would be escalated to a nurse, ultimately escalated to their provider, because we knew that that connection with the provider was so important. So they were starting to use the information they were collecting and starting these cycles of improvements to run experiments. And then they were starting to ask things like, what about the times of day that they're calling? Do they have higher success rates at certain times of the day? So great, again, just great problem solving from really frontline staff as they started to tackle this problem. And what they started to notice was they were making multiple attempts on all of our high-risk patients, but what about all of our other patients, and were we outreaching them? So they ran an experiment where they started focusing on what we called our non-high-risk patients. They started to get better results, and again, tracking data based on race, ethnicity, language as they did this. And then what they found was that the success rate, the success for booking a vaccine appointment, once they reached a patient, if a patient was Spanish speaking and was called by a Spanish speaking employee, that the likelihood of actually booking a vaccination appointment was 3 times higher than reaching out to an English speaking patient. So 45% of our Spanish speaking patients that were reached were being booked with an appointment compared to only 14% of our English speaking patients. So this was a great learning for us, that we realized that there was more barriers to our Spanish speaking population that we hadn't considered, and the outreach calls, direct outreach calls in their language actually made this huge difference. So you might say like, okay, well, that's kind of obvious, but I think it may be obvious from the outside looking in, but it's the team that was doing this work using PDCA thinking to discover and really drill down, okay, who are we reaching and how successful are we being? And then once you caught up and you tried that, then they tried the next experiment to keep reaching out and keep trying to reach those maybe more vulnerable or patients that are more hesitant, right? And soon we really started to see this play out in our vaccination numbers, as you can see here, right? So the percentage of Hispanic population patients that were getting vaccinated increased and actually started to exceed the ratio and the proportion in the city of Lynn. Language also played a huge factor in that, as well as age. So it was really exciting to start to see this effort. And then also I'll just highlight that for mobile vaccines was really our next step and our really outreaching to the community and overcoming, because at a certain point you reach this state where people didn't want to come into these mass vaccination, and there was more hesitancy, maybe just from even going into a site that big. And so in the summer, really launching our mobile vaccine program, again, with our partners. We hosted over 110 mobile clinics in all 7 wards of Lynn, and really focused on hiring staff into this program that spoke the language of the folks that we were trying to reach, right? So that they were relatable, dressing like the community, hosting fun events. And so this really started to propel our metrics even further as we started to dig in, again, week by week, tracking this to make sure that we were making a difference here. So I think just in summary, right, like this equitable distribution was really, really important to us as an organization, and it really played out, right? And you can see here from the graphs, when you look at our English, actually all other languages surpass, their vaccinations rates surpass our English population. And then with white, our Asian and Black and African American and Hispanic also surpass their vaccination rates, our white population. So it was a great effort that really focused on really taking that problem, working the problem week to week, day to day, to really make a huge difference in providing equitable distribution of vaccines for our community of Lynn. So I think in closing, I'll just say comparative, like how are we now, right? When we look back to 2021 and 2020 data, when you look at our race and ethnicity data of our employees, right? We were really developing problem solvers throughout the pandemic, and we were able to identify a number of people through this process that could move into supervisory roles. And slowly we were starting to shift those disparities in our management level. And so last year we were able to increase the proportion of Hispanic and Black and Asian managers, as well as increase the percentage of Black employees. So this was, it's a never-ending journey, right? But it's these slow gaps that we're starting to close that are really going to make a difference here. So hopefully I've been able to identify how you can take a problem that feels really insurmountable, like health equity, and solve it similar to how you solve any type of process problem, right? Start by defining the problem to solve, understand your current state, measure things in real time to learn quicker, and use PDCA thinking to incrementally improve that work. So hope, I don't think, is a strategy, but it's really through deliberate action and incremental improvement that we can start to tackle racism and health equity. So thank you.
Thank you, Kimberly. This is a great presentation. We learned a lot. Let me just look at the chat here. Sorry, at the Q&A. We've got a couple of Teresa Duran made a comment. It looks like a comment rather than a question. She said some medical assistants have an associate degree in science in medical assisting. She said that's formal training. And there's a question from, from Kristen. She's, was there an impact on rooming the next patient when the team began doing the checkout in the rooms?
Good question. So that was why it was so important that the checkout time in the room was really short, that as soon as the provider exit, we really want that MA to be entering the room and doing that in-room checkout. So closing that gap, and what we found that patients didn't want to wait, especially over 5 minutes, but that actually connecting patients to care and making sure they have their follow-up was really a really important step in their care. And oftentimes when we let them out and go to the front desk, they found that there was a line and then they would leave. So no, I would say that was what the problem solving effort was about, was minimizing that time so that you didn't hold up the room for the next patient. Good question.
And if anybody has any questions, just put them in the Q&A. We'll give it a couple other minutes. And Kimberly, I just want to make a comment that myself and some members of my case management team volunteered at the LynnTech site, and it was quite an experience. And I have to say, one of the things that I take away with me on that, and this guy had me in tears, was a black male came up, absolutely terrified to get the vaccine. Yeah. And I probably spoke with him for 5 minutes. He said to me several times, "Are you going to give me a shot that contains syphilis?" And I, directly talking about the Tuskegee study, and he was terrified. And it took me several minutes to talk to him, and he was with his son, and his son wasn't even sure when he was eligible he was going to get the shot. And it was heartbreaking. I mean, it's so real. These people, some of these communities have such real fear about vaccine and what it's going to do to them. I mean, he left with a smile on his face, and I was thankful that we all could help. But it was so real to him. It was really sad.
Yeah, there was so many stories like that, right? Where those conversations were so critical up front, having caregivers from the community volunteer like yourself and others, so that we could have those one-on-one conversations. And a lot of it was trying to find volunteers, right, that spoke our patient languages that were coming in, so that those conversations could happen. But yeah, it was heart-wrenching, to say the least, to see some of the hesitancy, and some of it wasn't overcome, right? Like you'd see the people that would escort their mom or maybe their sister, but they were like, "No way, that's their choice. I'm not getting it." And there was nothing that you could say that was going to convince them. So it's a lot to overcome.
Yeah, it really is. It doesn't look like we have any more questions. Maureen, are you seeing any that I'm not seeing here?
There were a few comments that people put in the chat versus the Q&A, if you want to check those.
Okay, let me see.
And a few more questions just came through.
All right. Yeah, there's one comment here. It says the myths and fears that exist need exposure to address nationally. That's absolutely a valid comment.
Yeah, and what can we do every day, right? That starts that conversation, both in our workplaces and with our patients.